Thanks for inviting me to speak on knee arthritis. My name is Zach Byrd, and I am an adult reconstruction total hip, total knee surgeon at JIS Orthopedics in New Albany, Ohio. That's right outside of Columbus. And we're going to talk about knee arthritis a little bit. So, so joints in humans are kind of like bearings. You know, we were talking about the hip joint, that's a ball and socket type of a bearing. The knee joint's a little bit different. A lot of people think of it as a hinge, but really it can move about 6 different ways. In this picture, you can see a lot of healthy industrial bearings that look good. There's ball bearings, roller bearings, caster bearings. But, you know, the truth of the matter is sometimes bearings go bad. And if you look at this bearing, it's probably not going to move all that well. And that's kind of the same as what happens in osteoarthritis in the knee. So in the knee, osteoarthritis happens to a lot of people before they actually know they have it. Like Dr. Lackey was saying, there are a lot of people that go from asymptomatic to symptomatic per year, and that's how we know how many people have arthritis. There's about 240 people per 100,000 people per year that become symptomatic. And the reasons that people develop arthritis, there's a lot of things that have to do with overall health picture, like body mass index or the ratio of our height to our weight. Again, increased weight is increased reactive forces on joints, and it tends to make our joints wear out quicker. Glucose intolerance or diabetes, cholesterol, hypertension, risk factors that we can't change, things like gender. Females get knee arthritis more often than males. We get arthritis more as we age, and then genetics. There's not an arthritis gene, but it does tend to be hereditary. So if your parents had arthritis, there's probably a higher chance that you'll have arthritis as well. And then there are things that we can potentially change or improve. Trauma on the joint, even if it's trauma that doesn't necessarily take you to the ER or get you surgery, those micro trauma events that add up over our lives and create internal issues with the knee, like meniscus tears or ligament insufficiency, things like that. Our occupation also plays into this a lot. Heavy lifting, repetitive knee bending, climbing stairs and ladders, things like that can add up over the years and contribute to the osteoarthritis picture. So again, where does osteoarthritis come from? It's kind of a cycle, and it becomes a little bit of a chicken or egg discussion after a while. There's little injuries, little strains, sprains, meniscus tears, ligament problems that add up over time and contribute to arthritis. And then arthritis, because it's an inflammatory condition, also contributes to those other pathologies, sprains, strains. You can exacerbate existing arthritis in the knee, especially with a little tweak or a twist. Meniscus tears can come first, or they can be degenerative, part of the arthritic process, and ligament injuries as well. An ACL tear, for example, could lead to arthritis down the road, whereas also the degenerative condition of arthritis could lead to ACL deficiency down the road too. So there's a cycle of pathology there. This is an X-ray that juxtaposes a normal knee with an arthritic knee. So on the left side of your screen, you can see a normal knee joint from the front. This is a right knee. So the top bone, the femur, that's the bone in your thigh. And then the bottom bones are the tibia, and the little one is called the fibula. And those are the bones in your leg, in your shin, down below your knee. The kneecap is there. It's sort of hard to see if you don't know what you're looking for, but it's this circle right here in the middle. So the things that I want to point out on this image, first of all, the color of the bone on the X-ray. It's homogeneous and gray. And then second, I would like to point out the space between the bones. It's not that there's nothing there. Cartilage is there. So that's where the bearing actually lives. The cartilage in the knee is invisible to the X-ray. So the X-rays go right through it and it's invisible. And if there's space between the bones, then you can infer that something is holding those bones open. The other thing that I want to point out is the general shape of the bones. They have nice smooth transitions and lines around the edges. And then if we come over here to the right side of the screen, we see a lot of things that are different. So going back to the color of the bone, you see the whitening of the bone. We call this sclerosis. And this is a reaction of the bone to the inflammatory changes in the joint. You can also see that the space between the bones is gone. So you can infer that the cartilage is not there anymore. And that's actually the pathology of knee arthritis. Arthritis isn't something that exists in the joint that you can go in and take out. Arthritis is the loss of something that should be in the joint, like the cartilage. And you can see that the bones are touching here on both sides. You also see that the edges of the bones aren't smooth anymore. They've got a little bit of extra bone here. These little bone spurs are called osteophytes. And these happen, the bone spurs aren't a problem in and of themselves. They're a result of the underlying problem in arthritis. Furthermore, going back to the idea of meniscal tears, if there's supposed to be a meniscus living between these bones, you can also probably infer that it's either gone or torn enough that it's now sticking out the side. And a lot of people notice that as well. The other thing that you notice is in this case, this person's knee has become more knock-kneed over time. We call that a valgus deformity. And arthritis can take a lot of different shapes, but in this case, this person is becoming more knock-kneed over a time as a result of the disease. When should you see a knee arthritis specialist? Well, it's really all about the symptoms. If you've got pain in your knee that limits your function and limits your ability to stand, walk, climb, lift, push, pull, carry, if you've got pain in the knee that keeps you on the couch when you should be out enjoying a sunny day, that's when it's time to see a knee specialist. When it gets really bad, you can have pain at nighttime or pain even when you're at rest. The knee often becomes stiff as a result of the inflammation. The balloon that the knee lives inside of is called a capsule. And if you remember on one of the very first slides, you saw a picture of joints and a little capsule around the joint. So that's the type of thing that the knee lives inside. And as it becomes more inflamed, that capsule thickens and the ligaments thicken, and then the joint becomes stiff. That makes it difficult to navigate environments like uneven terrain or stairs. It also leads to mechanical symptoms like a catching or a locking up of the knee. A lot of times my patients will say if they sit for a little while, then the knee gets really stiff and they've got to limber up before they can really do much. It also leads to an increased fall risk because that pain creates a reflex that then makes the joint want to give way when you're standing on it and it's painful. So what treatments are available for knee arthritis? Well, there's a lot of non-operative treatments. I like to hearken back to something called the AAOS Clinical Practice Guidelines because it does a good job of parsing out what treatments are worthwhile and what treatments may not be. As previously discussed, knee arthritis is typically better tolerated for more time than hip arthritis, and it's not quite as debilitating, but it gets bad in the end. So the clinical practice guidelines most recently updated recommend assistive devices of ambulation like walking sticks, canes, walkers, bracing. There are certain types of braces that can be prescribed for patients if there's a deformity that we're trying to correct. They act to put the weight-bearing axis of the limb through a healthier part of the joint and take the stress off the worst part of the knee. There are topical and oral non-steroidal anti-inflammatories that can be prescribed or even over the counter for you. Exercise, motion is lotion. I usually say movement is medicine, but same basic principle there. Physical therapy can be helpful. If we strengthen and stabilize the muscles around the joint, then we're making the joint not have to work as hard to do its job. Furthermore, it can increase range of motion potentially and help with stiffness. Weight loss. Each pound of your body is somewhere in the 3 to 5 pounds range for each one of your knees. So even a modest loss of weight, 10 pounds, that's like leaving a 40-pound backpack unstrapped in the closet when you wake up in the morning. Education, self-management, activity modification, and then the corticosteroid injection. A lot of people refer to it as cortisone. There are a lot of different names for steroids, and there are a lot of steroids that work well. But a steroid that is injected into the joint is an anti-inflammatory treatment that can help with pain. Do the non-op treatments work? Well, sometimes. A lot of times, if the knee is earlier on in the disease process, they may work better. This is an article that I like that was actually done overseas, and it looks at almost 200 patients with osteoarthritis that were treated non-operatively and followed for 6 years. At the end of that study time, 33% of those patients had elected to proceed with a total knee. If you look at the same article that was written for total hips, it's 2/3 of patients that have elected for surgery. So knee arthritis is a little better tolerated. A total knee replacement is an operation where this is a knee model where we make special cuts on the end of the bone in order to remove that diseased cartilage, and then we resurface it with metal and plastic parts. In the knee, the metallurgy is a little bit different, but we remove the cartilage containing bone and we prepare it to accept the new bearing surface. And on the kneecap, which would be right here, we also resurface the underside of the kneecap with that specialized plastic that we referred to before. Many times there are a lot of different materials that a knee replacement can be made of, but a lot of times the thigh bone component is made of cobalt chrome, and then the tibial component is made of titanium, and then that special plastic, that polyethylene in the center, is a very wear resistant plastic. And so after a knee replacement, the day of surgery, we typically do this procedure as an outpatient. Once the patient is able to cross the T's and dot the I's for discharge, they're allowed to leave the center. And on the road home, there are a lot of patients that live right next door, but there's a lot of patients that have to drive a certain ways. We recommend that you get out of the car every hour or so and stretch your legs. Postoperative pain control is managed with a treatment strategy called multimodal pain therapy. And I usually refer to that as the 4 ninjas. So if you think of 4 different ninjas all attacking one enemy from different angles, that's how we manage pain. So we prescribe different pain medications that work together and are stronger together than any one of them by themselves. And that tends to work very well for patients. We also prophylax against blood clots. That's one of the things that we really don't want to have in the postoperative period. So we typically recommend patients walk around their home every 90 minutes. It doesn't have to be a 5K, just a lap around the living room. We also typically prescribe some kind of anticoagulant that's based on the patient's individual profile and their risk stratification. And then we start rehabilitation right away. And there's a lot of different ways that we can offer rehabilitation as well. It could be outpatient physical therapy. We could deliver it virtually. You could use a home exercise program. But then the first 2 to 3 weeks, that's when the pain postoperatively subsides. Patients tend to turn the corner. They de-escalate from those narcotic pain medications. Their wound heals appropriately. They transition from a walker to a cane. And we continue prophylaxing against DVTs. We're progressing in PT. We like to see less than 5 degrees extension and about 90 to 110 at the first follow-up at about 2 weeks. And then within the first 6 weeks, that's when we are off the pain medications. We don't use any canes or walkers anymore. We have a scar instead of a surgical incision. We complete our DVT prophylaxis. Our blood clot medicine is done at that point. We complete physical therapy, and pretty much patients are off to the races, and they can do more or less what they want to do. It's still easy to have a big day at 6 weeks, but it's getting a lot better. And then after the first year, we really hope that there's no pain medications required anymore. The wound is just a scar. There's no canes or walkers. There's no physical therapy. And ideally, you've forgotten that you had surgery and you just live your life pain-free. So then one more note on the survivorship of the so this is the concept that a total knee has a shelf life. I still get a lot of patients that said, well, my primary care doctor says that a knee only lasts 10 years, so I should wait. Well, I don't really know that that's true. If you look at 10 years survivorship data, ubiquitously, universally, everybody who publishes on 10-year total joints has at least 90%, probably closer to 95% of those joints are in and working fine at 10 years. There's about a 1% per year rate of revision surgeries. So one way to look at that is there's a 1 in 5 chance that maybe you've needed a revision in 20 years, but there's a 4 in 5 chance that it's in there working just fine. And I guess I would rhetorically ask, do you want to live now or do you want to live later? Because the knee's going to last either way.